This presentation represent about image evaluation of A.P. shoulder. I am Amirah Shuhada from class NHSI4B will present to you about this topic related to the subject M.R. D444 image evaluation. List of content for this presentation are radiographic anatomy, positioning criteria, exposure factor criteria, and radiographic image evaluation using Paceman method. What is Paceman? Paceman is a technique used to evaluate an image of X-ray. Paceman stands for P, projection and positioning, A, alignment, C, collimation, E, exposure factor, M, marker, A, aesthetic value and N, name and patient's identification. Next, we move on to the radiographic anatomy of A.P. shoulder. In projection of anterior-posterior of shoulder, at the posterior border, there is structure of acromioclavicular joint, acromion bone, clavicle. At the inferior border of shoulder, it includes the structures of glenoid fossa, coracoid process, scapula fossa and humeral head. At the lateral border of shoulder, it includes the structure of lesser tubercle, greater tubercle, humeral body. Next we will move to identify the positioning criteria for A.P. shoulder rotation. This criteria is to evaluate the details of the scapular body, glenoid activity and clavicle. The correct evaluation for no rotation of A.P. shoulder should visualized glenoid fossa. Superolateral border of scapula seen without superimpose with thorax, posterior part of glenoid fossa were superimposed with humeral head and superior scapula angle were superimposed with midclavicle. If the shoulder if rotated towards the affected side, the scapular body appears wider, the thorax is superimposed over the superolateral scapular region, the glenoid cavity and scapular neck were in profile, clavicle were seen longitudinally foreshortened and medial clavicular ends shifted away from vertebral body. To improve this position, rotate the patient away from the affected shoulder into A.P. projection with the shoulders positioned at equal distances from the IR. If the shoulder was rotated towards the unaffected side, scapular body were drawn from beneath the thorax and seen foreshortened. The thorax were superimposed over a smaller amount of the scapula, glenoid cavity well demonstrated and medial clavicular end was superimposed over the vertebral column. To improvise this positioning, rotate the patient toward the affected shoulder into an AP projection with the shoulders positioning at equal distances from IR. The correct criteria to evaluate correct shoulder rotation should well visualized glenoid fossa, superolateral border of scapula seen without superimpose with the thorax, posterior part of glenoid fossa were superimposed with humeral head and superior scapula angle were superimposed with midclavicle. No need improvement for this positioning. Another criteria to evaluate correct positioning for A.P. shoulder is evaluate shoulder tilting. This criteria is to determine the degree of longitudinal scapular foreshortening. If it's incorrect tilting, the scapula is demonstrated without foreshortening when midcoronal plane is vertical and positioned parallel with the IR. If the patient was tilted anteriorly, superior scapular angled were demonstrated superior to the midclavicle. The greater tubercle was visualized in profile laterally. The improvise this position, tilted the upper midcoronal plane posteriorly until it is parallel with IR. If the patient was tilted posteriorly, the superior scapular angle was demonstrated inferior to the clavicle. Lesser tubercle was demonstrated in profile medially and superimposed of greater tubercle and humeral head. To improvise this position, tilt the midcoronal plane anteriorly until it is parallel with IR. The correct criteria to evaluate A.P. shoulder without tilting should demonstrated scapula without foreshortening when the midcoronal plane is vertical and position parallel with the IR. No improvement is needed. Now we will discuss about the exposure criteria for this projection. If it is in good contrast, it should demonstrate thin structures of bony cortical outline of acromion and thick structures of bony cortical outline of glenoid or coracoid fossa. If it is in good density, It should demonstrates thin structure of bony trabecular pattern of acromion and bony trabecular pattern of lesser tubercle or humeral head. If all of these criteria is shown in a radiograph, it showed it is adequate exposure. If the radiograph is overexposed, thin structure of bony trabecular pattern of acromion cannot be seen. However, the thick structure of bony trabecular pattern of lesser tubercle or humeral head can be well seen in the radiograph. This showed that the image is high in density. To correct the overexposed radiograph, one should decrease the M.A.S. by half. If the radiograph was underexposed, the thin structure of bony trabecular pattern of acromion can be seen, but the thick structure of bony trabecular pattern of a lesser tubercle or humeral head cannot be seen clearly. Thus, to correct this, radiographer should double M.A.S. by 2. If the radiograph is overpenetrated, showing that the exposure is in high contrast. The thin structure of bony cortical outline of acromion was not demonstrated. The thick structure of bony cortical outline of glenoid or coracoid fossa well demonstrated. To correct this exposure, radiographer should decrease K.V.P. by 15%. If the radiograph is underpenetrated, showing that the exposure is in low contrast. The thin structure of bony cortical outline of acromion was demonstrated, but the thick structure of bony cortical outline of glenoid or coracoid fossa was not demonstrated. To correct this exposure, radiographer should increase K.V.P. by 15%. Next, we will go to the topic about radiographic image evaluation using Paceman. We will evaluate the radiograph of A.P. shoulder using Paceman method. This is radiograph of A.P. projection of a shoulder. This is A.P. shoulder because glenohumeral joint, clavicle, proximal third of the humerus and superior scapula are included within the exposure field. Glenoid cavity is partially demonstrated with the humeral head superimposing it. Greater tubercle is partially seen in profile laterally and the humeral head is partially seen in profile medially. This shoulder was demonstrated a rotation as the scapular body appear wider on the image. The thorax was superimposed with the superolateral scapular region. Medial clavicular ends shifted away from the vertebral column, and this indicate that the patient was rotated towards the affected side. To improve the positioning, rotate the patient away from the affected side into A.P. projection with the shoulder positioned at equal distances from the I.R. This image also demonstrated shoulder tilted as superior scapula angle demonstrated inferior to the midclavicle. Lesser tubercle demonstrated in profile medially. There is superimposed of greater tubercle and humeral head, and this indicate that the shoulder was tilted posteriorly. To improve this position, tilt the upper midcoronal plane anteriorly until it is parallel with I.R. The alignment between X-ray tube and cassette for this image cannot be determined as there is no evidence of four borders of collimation. The alignment between X-ray tube and patient for this image cannot be determined as there is no evidence of four borders of collimation. The alignment between cassette and patient for this image was incorrect as the distances between the edge of film to the central structure are not equal laterally. The centering point for this radiograph cannot be determined as there is no evidence of four borders of collimation. However, the standard centering point for this projection is central ray is at 1 inch inferior to the coracoid process. Collimation for A.P. shoulder at the superior border should cover until acromioclavicular joint, clavicle, scapular spine and glenohumeral joint. At the inferior border, the collimation should cover until humeral head, glenoid fossa and coracoid process. For lateral border, the collimation should cover soft tissues of shoulder, humeral head and humeral body. This radiograph showed adequate exposures as well as adequate density and adequate contrast. This is because thin structure of B.T.P. of acromion and thick structure of B.T.P. coracoid fossa well demonstrate. Thin structure of B.C.O. acromion and thick structure of B.C.O. coracoid fossa well demonstrate. Thus, no modification of exposure is needed, just maintain the exposure. There is evidence of anatomical marker seen in the radiograph. The marker was placed appropriately on the right side of the patient, not superimposed with the region of interest. The film size used is 24 x 30 cm, which is sufficient to demonstrate all region of interest. There is no evidence of artifact seen in the radiograph. There is no evidence of patient's name and identification, date of examination, place of examination and radiographer's name were visualized in the radiograph. So as a summary, should this radiograph accepted or rejected? This radiograph is rejected because there is no evidence of patient's name and identification, date and place of examination and radiographer's name in the radiograph. The positioning is also incorrect and there is evidence of digital marker visualized in the radiograph. This is the list of references that was being used by me for this presentation. Before I end this presentation, thank you for your attention and thank you for a great day.